Okay, hi everyone, and welcome to our webinar, MACRA for Psychologists, What's Changing About Medicare's New Quality Payment Program. This is the second webinar on MACRA, brought to you by the APA Practice Organization, a legally separate companion organization to APA that advocates for psychologists on reimbursement issues. I'm Julie Edwards-Ashman, and I'll be moderating today's webinar. I'm joined by our presenter, Diane Padula. Diane is Director of Regulatory Affairs at the Practice Organization, and she is also an expert on Medicare and the Medicare Access and CHIP Reauthorization Act, also known as MACRA. Before Diane starts her presentation, I'd like to cover a few logistics. First, everyone is going to be in listen-only mode during the webinar. And if you have a question, please type it into the chat box. There will be a short Q&A session at the end of Diane's presentation. You can also download the slides from the presentation on the dashboard of this webinar. And you can also email additional questions to practice@apa.org. Please note that this webinar is being recorded, and we will email you a link to the recording within 24 hours. So I will now turn things over to Diane.
Thank you, Jewel. As Jewel mentioned, I'm Diane Padula. I'm the Director of Regulatory Affairs for Practice. I've been here a fair number of years, so those of you who've been Medicare providers and have interacted with Practice probably have met me or communicated with me before. I'm specifically here today to talk to you about the changes in Medicare's quality payment programs. Sorry about that. Trying to make sure I've got the screen moving correctly. As Jill mentioned, MACRA refers to the Medicare Access and CHIP Reauthorization Act, which was passed and put into effect back in 2015. This was a very important bill and law for all healthcare providers because it repealed a part of the Medicare formula that was known as the sustainable growth rate. Many of you may recall hearing us talk many times about the SGR cut. What this particular law did was it took away the SGR and it replaced it with quality payment programs. And I'm going to talk a little bit more about those that are most applicable to psychologists. There are really two new quality payment models: the Merit-Based Incentive Payment System and Advanced Alternative Payment Models. For purposes of today's discussion, we are going to focus on MIPS, and the reason for that is the vast majority of clinicians, not only psychologists, but all healthcare providers, are going to at least start out under MIPS. It is not as common for psychologists to be involved in alternative payment models, not simply because most of them are focused on primary care services, and so it doesn't really fit the psychologist model of practice quite as well. Down the line, as integrated care increases, we probably will see more psychologists in these models, but for today's purpose, we're going to concentrate on the program that psychologists are most likely to end up being involved in, and that would be MIPS. Where did the Merit-Based Incentive Payment System come from? Well, on the one hand, it is something new. It just became part of Medicare in 2017, so it is brand new this year. The different components of MIPS have actually been around for some time. The quality component of MIPS is what many of you will recognize as the program formerly known as the Physician Quality Reporting System, or PQRS. Other components, for example, the advancing care information, which I'll talk about a little bit later, that came from meaningful use and the EHR incentive that many of the other healthcare professionals were involved in. The cost and resource part of MIPS is what's known now, or had been known for physicians, as the value-based payment modifier. If you're thinking that that does not sound familiar, it's because psychologists never came under that particular program in Medicare. This is just to illustrate that MIPS, on the one hand, is new, but it's new because CMS essentially took pieces of previously existing programs and combined them into one. So what you will see when we talk a little bit later about the quality measures in MIPS are essentially the measures that were in PQRS. There have been some changes, but many of them are going to be very, very familiar to you if you previously did PQRS reporting. What's most important to understand about MIPS is that it is a high reward but also a high risk program. I'll show you a little bit later some of the impacts that MIPS will have on payments. This is always a little bit of a lag time. MIPS uses reporting from a particular year that does not impact payment until a couple of years later. But you're going to see over time the idea for Medicare is to be rewarding quality as opposed to simply volume of services. Adjustments from MIPS to your payments will be neutral, positive, or negative. I think it's important to understand that CMS starts with the assumption that the adjustments will be neutral. A better way to think of that is CMS is assuming that most providers will essentially be considered average. And so what they'll be looking most closely at will be superior performance, which will earn people bonus payments, or less than average performance, which in turn will trigger penalties. And looking at the chart that you see now, you can tell what those penalties will be for several years to come. And keep in mind the year that is listed here is the payment year. So for example, people who are reporting now under MIPS, the physicians and what we call physician extenders, such as nurse practitioners and physician assistants, what they're doing in 2017 does not impact their payment until 2019, at which time, if they are not falling in the average category, then they're either at risk of a 4% penalty or in line to earn an additional 5% in bonus payments. And those amounts will grow. So in 2020, you're up to 5%. 2021, you're up to 7%, and from 2022 and on, you're talking as much as 9%. So when you think about it, 9%, either in terms of a hit or in terms of a bonus, is really a fair amount of money. There also will be additional bonuses available for superior performance. And a little bit later, when I talk about some of the ideas that CMS has in mind for 2018, you're going to see there's even a few more categories where CMS be trying to put some potential bonus points to help people achieve superior performance and essentially to help them earn money from doing this work. How does MIPS affect psychologists? And I realize in looking at some of the questions that people submitted in advance of this webinar that this obviously was one of the biggest concerns on their mind. The truth is, right now, MIPS does not affect you. You are not yet defined as eligible clinicians in MIPS, and that's the key term of art that's required in order to be part of this program. Psychologists are not the only ones who don't fall in this category yet. Social workers, physical therapists, occupational therapists, essentially anyone who can independently bill Medicare but is not providing primary care and evaluation and management type services is not yet an eligible clinician at MIPS. The earliest point at which you would be added to MIPS is 2019. And I stress earliest because one of the questions that was raised in advance was, would psychologists definitely be added in 2019? And if you look at the actual language in the law that was passed, it does not say that all of these groups are definitely added in 2019. It says the Secretary has the discretion to add them in 2019. So we knew that psychologists would not become part of MIPS until 2019 at the earliest. We really will not know until sometime next year when we see what CMS is talking about for 2019 to know whether for certain psychologists will actually be brought in at that time. The expectation is that all the other groups will be added for 2019, but it is not for certain until CMS says that it is. So what this means for 2017 and 2018 is that you are not part of MIPS, and therefore you are not required to report any MIPS measures. So what I was talking about a little bit earlier in terms of impact on payment for 2019 and 2020, that does not affect you. There will be no impact on your payments until you are actually part of MIPS and reporting under MIPS. So you will not see any changes to your payments this year or next year. And that means that essentially the payments you've been receiving are going to stay static. Unless there are changes to the CPT codes and their values, then the payments you've been receiving will stay the same. I always caution people, don't forget there is that annoying 2% cut out there for sequestration, which Congress put in place several years ago and which is going to continue for several more years. So that has nothing to do with MIPS or anything else with quality payment programs. That's simply an additional piece that Congress imposed. But for the most part, again, absent any changes in CPT coding, you should not be seeing any changes in your payments. All right, this is probably the most popular topic whenever I'm talking about MIPS, and it certainly makes sense because it's the one that is going to have the most direct impact on the vast majority of psychologists in Medicare. MIPS contains something known as a low volume threshold exemption, and what that means is if you fall within the threshold, then you are exempt from MIPS reporting. So no requirement to report any of these categories, and consequently, no impact on your payments a few years later. Now, for 2017, for the folks who are in MIPS, if they have 100 or fewer Medicare patients, or they are billing Medicare for $30,000 or less in Medicare allowed charges, then they do not have to report under MIPS. You see a line at the very bottom about all first-year providers are also exempt. That has nothing to do with the low volume threshold. It's simply an across-the-board exemption. I needed someplace to put it, so it fit fairly nicely here. So anyone who is in their very first year as a Medicare provider is also automatically exempt, no matter how many patients they see or how many charges they're billing to Medicare. And the reason CMS has done that is it wanted to reduce the burden on very small providers. It recognized that treating a practice that sees hundreds and hundreds of patients or bills Medicare for a significant amount of money is basically not playing the same game as a much, much smaller provider. And so they determined that even by exempting a number of providers, they were still able to account for the vast majority of Medicare beneficiaries. And so this is an opportunity for small providers to be able to continue in Medicare without having to take on additional reporting requirements, which I think, as we know from PQRS, many of them found to be quite challenging. Now, this is the latest in terms of what CMS is proposing for 2018. And again, this is very critical information for psychologists. They would like to raise the low volume threshold to up to having 200 or fewer Medicare beneficiaries or $90,000 or less in Medicare charges. We knew many psychologists would have been out under the current low volume threshold. If CMS continues with this expansion and raises it to this level for 2018, clearly a significant number of psychologists who see Medicare patients would then be exempt and not have to deal with MIPS reporting at all. So this will be decided relatively soon because all this has to be in place before 2018. We will be seeing a final rule on MACRA most likely in either October or November, so we will know by then what CMS plans for 2018. My hunch is that this is something that will be very strongly supported. We know in our comments to CMS we are definitely going to support this expanded low volume threshold. So again, looking ahead to 2019, even if psychologists are added with a low volume threshold of this magnitude, we honestly would expect that the vast majority of them would not be required to report under MIPS.
Hi, Diane. This is Jewel. We just have two questions kind of related to the previous two slides.
Sure.
So the first question is about the previous slide. Is that $90,000 in charges per year?
Yes. What CMS does is it looks at your billing for the previous year and then notifies eligible clinicians whether they would be exempt under the threshold for the year going forward.
Okay, great. And then we have another question related to the $30,000 threshold. And that is the $30,000 threshold for what we bill or what is allowed by Medicare?
What is allowed by, it's the allowed charges, it's what Medicare allows.
Okay,
so if you're telling Medicare what your fee would typically be, which is probably higher than what the Medicare allowed amount would be, it's based on Medicare's amount.
Okay, great. Thank you, Diane.
All right. Some other interesting proposals for 2018. MIPS does include something that's referred to as virtual groups, and the idea behind this was to allow eligible clinicians that were not in a position on their own to be part of MIPS to join with others, specifically for the purpose of being able to do MIPS reporting. And that's regardless of their specialty or regardless of their location. Now, CMS still hasn't ironed out all of the requirements for a virtual group, but it wants to slowly start to move forward with this option. And so they are putting it out there that for 2019, that they would be starting to move ahead with some of this. One of the things that would happen is that it would have to be either a solo or a group of less than 10 partnering with others that were in similar categories. So you could not have two very large practices trying to join together as a virtual group, because the argument would be that they would already be capable of going out and qualifying as a group to begin with. This is to bring in the folks who on their own would not exceed the low volume threshold and therefore could not take part in MIPS. And I actually want to correct myself on that. I said 2019. This one would be for 2018, so it would be starting in the following year. Again, keep in mind, psychologists aren't yet in MIPS at all, so they can't be planning for 2018 to join with another provider to be part of a virtual group, because we have to get you into the system to begin with before you can even consider that. But it is just to let you know that that's going to be one possibility. Now, there is something that, even though we're talking about a proposed rule for 2018, CMS discussed but also said they're not ready to handle as early as 2018. So here's something they've actually put forward as a proposal for the following year, for 2019, just to get people thinking about it, and I think more importantly to allow people the opportunity to weigh in on whether they support this proposal or they would want to recommend that it be done a little bit differently. And that is the idea that CMS would allow eligible clinicians to opt into MIPS even if they already fell under the low volume threshold. And here's the key point. What CMS is thinking of now is if you met one of those two factors, so you had more than 200 beneficiaries, but you billed less than $90,000. Under the low volume threshold, that would mean you would be exempt. Medicare wants to say if you meet one threshold but not the other, we will give you the option of MIPS reporting. So you don't have to, but you could do it if you wanted to. Now, our position on this is we don't think that you should still have to require that you meet one of those two factors. We think anyone who is practicing and billing Medicare should have the option to report under MIPS if they want to. So in other words, even if your numbers were low enough that you fell under the low volume exemption, it should be up to you, the provider, whether or not you want to sit on the sidelines or you want to be part of MIPS, you want to show that you demonstrate quality, and most importantly, that you make yourself eligible for that bonus money. So that is one of the things that we are going to be advocating, and I just want to be very clear to people about what it is that we'll be asking CMS to do. We will be asking them to allow all eligible clinicians to decide whether or not they want to report under MIPS, regardless of how small their practice is. We are not in any way saying that people should not be exempt under that low volume threshold. We're arguing very strongly to retain the low volume threshold and to raise it to the level that they are proposing for 2018. So in a way, we're asking for both things at once. We want to make sure psychologists whose practices are small are exempt, but at the same time, we want the door to be open so that if any of those small practice psychologists would like to report under MIPS, that they will have the opportunity and potentially could earn bonus money. A few other things that are coming up for 2018, and again, keep in mind these are all proposals. CMS wants to hear from the public whether or not these are things that they should be doing. They are looking at an exemption for small practices, particularly on the advancing care information, which is the part that's related to electronic health records. That is, if a small practice would find it a hardship, for example, a financial hardship to invest in electronic health records, that could be one ground for making them exempt. They also want to put in some extra bonus points for small practices, and by small practices, CMS means a practice of 15 or fewer clinicians. There's also suggestions for bonus points for treating complex patients, and one of the things we will be doing in our comment letter is pointing out some different methods that CMS can use to determine what is considered a complex patient, because we want to be very careful that they are not using methods that potentially would work for medicine but would not necessarily work for psychologists and or other mental health providers. They are also talking about extending what is known as pick your pace for an additional year, and I'll show you in just a second what that's all about. Recognizing that 2017, the very first year of MIPS, was going to be a very challenging one for the groups that were required to report, CMS came up with the idea of deciding what track you would be on for MIPS reporting, and it gave people three options. You could submit a very small amount of data. Literally, you could submit one measure in the different categories, and that alone would save you from receiving a penalty 2 years from now. You could submit 90 days worth of data, and you could also be assured that you'd have a neutral payment adjustment. On the other hand, if you wanted to dive in a little bit deeper, you could submit up to a full year of data and potentially earn one of those bonuses that we were talking about. So they gave people several options, really from doing the very bare minimum all the way up to engaging in full-scale reporting. And so it looks like they will try to continue that for a second year, again, to give people more time to really get used to the system, understand how it works, and potentially protect themselves from too much of a pay cut if they're not doing it right. One of the advantages of psychologists not being included right away, it's given CMS more time to work with this program. It's given us an opportunity to watch from the sidelines in terms of what they're doing with physicians, what's working, what's not working, what they're making adjustments, about. So, well, we always want to make sure that psychologists are recognized as full-scale healthcare providers in Medicare. This has been one program where there potentially have been some benefits because it's been such a big change compared to the way Medicare payment was run before. Okay. All right. Now, again, I want to be very careful how I explain this because I can see where it would be confusing to many people. I have just spent all this time telling you that psychologists are not part of MIPS, they're not defined as eligible clinicians, they don't have to worry about reporting, and there's no impact from MIPS on their payment in 2019. So why have we been talking about MIPS reporting, and if any of you have followed some of our other publications, why have we been talking about a registry for MIPS reporting for psychologists? Well, the reason simply is that CMS is making available to all groups that are not yet defined as eligible clinicians the opportunity to essentially practice MIPS reporting. And this is true for both 2017 and 2018. And the reason they've done that is because they do recognize that it is such a, I don't want to say complicated, but it's a much more multifaceted program than PQRS was. And they want to give people the opportunity to learn as much about it as possible before they actually reach the point where it might impact their payments. So again, offering people the opportunity who are not required to report to practice reporting this year and next year. Any data that you report will not affect your Medicare payments in either 2019 or 2020. It is strictly voluntary. You will receive feedback on what you've done. So that would let you know, did you satisfy the categories that you reported on? And if you did not, then why not? Something to think about, not required to do it, but if people do see themselves, even in light of those new proposals for the low volume threshold, if you're seeing enough Medicare beneficiaries, if you are billing Medicare for a significant amount of money and believe that it is likely that you will be reporting in 2019, then it might be something you want to consider, if not this year, then next year. So you at least have an opportunity to become more familiar with the program before you jump in at the point where Medicare is talking about either potential bonuses of up to 9%, but on the flip side, potential penalties or losses of up to 9%. How do you report under MIPS? Really pretty much the same way that you reported under PQRS if you were familiar with that system. You can do it through claims. You can do it through a registry. And what we have done, we took the APA-PO PQRS Pro registry that we developed with HealthMonix, and it is now MIPS Pro. I'll have a little bit more information on that later on. But that option is available to people. If you've used it before, you're familiar with how it works. People can also do reporting through certified electronic health records and through what are known as qualified clinical data registries. A few changes in terms of how people will go about reporting. Again, this has to do with some of the things that CMS is going to be proposing for 2018. For right now, if people are reporting, they have to pick one of those methods and stick with it. So if you start with registry, you have to use registry for all of the different components of the program. What CMS is proposing for 2018 is that you be allowed to use multiple reporting methods. So if for some reason you wanted to report quality measures through claims, but you wanted to do advancing care information through a registry, that would be an option for you. As I said before, these are proposals. It remains to be seen whether CMS will truly adopt them, but just an idea of where they might be going on this and their continuing efforts to build flexibility into this program.
Hi, Diane.
Hi.
We have a question about trial reporting.
Okay.
It says, we are a group of psychiatrists, psychologists, and social workers. Would we be able to submit as a group? And if so, would they take out the non-eligible clinicians as trial data?
Well, The psychiatrists are required to report. If everyone was reporting as a group, then the reporting for the psychologists, social workers, anyone who is not yet an eligible clinician should be treated strictly as trial data. And so performance feedback would come, but there would be no impact on their payments. But the psychiatrist submission would end up being reflected in the payments 2 years from now.
Okay, and if you don't report at all, and if you are not an eligible clinician, is there a penalty?
Absolutely not. Absolutely not. If you are not an eligible clinician for 2017 or 2018, then nothing, you are not responsible for anything in MIPS. There is no impact on your payment.
Okay, great. Thank you.
All right. And actually, this kind of leads right into what is happening for people who have to report right now. If you are an eligible clinician and you don't do any reporting, then expect that in 2019 your payments are going to be cut by 4%. As I mentioned, if you submit even the smallest amount of data, like one measure in each category, then you at least would avoid that 4% cut. If you submit 90 days of data, then depending upon how successful you do it, you would get either a neutral adjustment or potentially a small positive adjustment. To receive the full 4% as a positive adjustment, you would have to submit a full year's worth of data. Now, how is MIPS scored? Okay, this chart may look a little odd at first, but let me explain it. These are how the components are scored and weighted for 2017. Quality is going to be 60% of your score. Advancing care information, which essentially is the electronic health records meaningful use category, is 25%. Practice improvement activities are 15%, and resource use, which represents cost, is not going to be factored in. And that's why when you look at this slide, you see some numbers that are in brackets. Originally, quality was only supposed to be 50%. Resource use and cost was supposed to make up 10% of the composite score. CMS decided not to include resource use at all, and so it had to make up for that 10%, and what it did was it added more onto quality. And this is the way it would continue to be for 2018. They're not proposing to make any changes to that. How would you go about participating? Well, individual clinicians, you'd be using your NPI. Groups would be reporting using their tax identification number, and all categories need to be basically reported the same way. So you can't jump back and forth. You can't be an individual clinician for purposes of one portion and be a group for purposes of the other. So you're kind of all in as a group or you're not. One thing to keep in mind, some people may decide that group reporting is not in their favor, depending upon how they feel about MIPS, because if as individual clinicians they would all be under the low volume threshold, then they may wish to then not explore a group option, which would then bring them into MIPS. Flip side of that, if they want to, then there's the opportunity for bonus payments by definitely making sure that they report as a group as opposed to individuals. Okay, what does MIPS reporting actually look like right now? Well, a little bit easier than the old PQRS reporting. You are down to only 6 measures, so not the 9 that PQRS had risen up to. One outcome measure is expected to be included, but if you don't have an outcome measure, then there are high priority measures that you can select from. You can select individual measures, or you can select a specialty measure set. And this time around, we actually do have a mental behavioral set of 25 measures. Again, many of these are former PQRS measures, so they will look familiar to any of you who did PQRS in the past. One thing that's changed, and I think this is very advantageous for many psychologists, dementia members are no longer a group measure. So whereas before under PQRS, you had to be in a position to report every measure that was in the dementia group, and you had to report it through a registry. Now those measures have been broken out. They've actually had a few changes made to some of them, and they are now available as individual measures. So you are not required to have to meet every measure in that group anymore. I have a link here to the measures online. I will say in general, this new quality payment program website of CMS is much, much, much more user-friendly than some of the previous PQRS web pages were. The PQRS web pages were just chock full of information, but unfortunately, much of it was buried so deep that you literally had to dig through page after page after page to find it. And I know from speaking with many members over the years that they found it very, very difficult to navigate some of those pages. I think people who need to take a look at the quality payment program under these new web pages for CMS are going to find that it's much more user-friendly, much more easier for them to see what it is that they're looking for, find what they're looking for, and just basically maneuver through the information that's there. You can download the measures into an Excel file. You can't, unfortunately, then just use the online list and directly report through the website itself. But again, it is much more user-friendly. You're going to find it's something that has pretty much whatever you're looking for right at your fingertips. I'm just going to briefly run through these, again, all available online, but you're going to see there's some of the same ones you noticed from under PQRS. ADHD, follow-up care for children, adherence to antipsychotic medications for individuals with schizophrenia. The adult MDD, you will see, is still there. The antidepressant medication is still there. Care plan is still there. Child and adolescent major depressive disorder, suicide risk assessments. One that I don't think many people either were able to use previously, but closing the referral loop and receiving a specialty report. That may or may not work for you depending upon which side of the equation you're on, but it is something at least worth taking a look at. And then the different dementia measures. For those of you who did the group measure reporting last time, we'll see just a few changes here. There were a couple from the group that came out, and there were a couple of others that basically were combined. But there's a number of different issues here under dementia. We found in general that the dementia group was really popular with many of our neuropsychologists, given the type of patients that they deal with and the work that they're doing. So again, very, very good opportunity for people in neuropsychology or people who are doing primarily work with the elderly. We still have the depression remission measures, both at 6 and 12 months. We still have the PQH9 tool that's available. Documentation of current medications in the medical records. I think everybody's familiar with that one from PQRS. That was the one that, on the one hand, worked no matter what diagnosis the patient had or what CPT code you were billing, and the downside of it was that you needed to be using it for every visit, so that was always a little bit of a challenging one for some folks. The elder maltreatment screen is still there. Follow-up after hospitalization for mental illness is still there. The preventive care and screenings are still here, including the body mass index. I know I've had many conversations with psychologists. If by chance that works for your practice, that's great. If it doesn't work, don't feel you have to. Try to come up with a way to do it, especially now under MIPS where the reporting is even lower. You're only looking for 6, you're not looking for 9. Same thing with high blood pressure. If it works for your practice, fine. If it doesn't, you've got many, many others to choose from. Your tobacco use and unhealthy alcohol use are still here. Now, onto the advancing care information category. One thing I want to start off explaining to people, because I know this is of great concern to psychologists since they did not have the opportunity to take part in meaningful use. You were never eligible for the AHR incentives, so for many folks this was just not something that they had to deal with. Totally understandable. However, One piece of good news is that if you do find yourself needing to do MIPS reporting, what CMS has done for the current eligible clinicians is if they were not doing meaningful use the previous year, then they are exempt at least for the first year for this entire category. So if this is not something that pertained to your practice, you had no experience with it, then at the very least, you would be expected to be exempt from this particular category the first year you are in MIPS. And all that would happen is that CMS adjusts the weighting, so then way more weight goes on quality, way more weight goes on the clinical improvement activities, and you are not held responsible for this. What will be interesting to see will be going forward then what happens after that initial year. What does CMS then still expect people to do? Are they going to be expected to have instituted electronic health records in one way or another, or will they continue to simply readjust the weighting on these points? Clinical practice improvement activities. These are kind of a fascinating set. Some of them, when you look closely, will probably remind you of PQRS as well. There's definitely a little bit of overlap in terms of some of the things that used to be part of PQRS and that are now part of practice improvement. But there's also some much more broad-scale activities in this area, really designed to promote safety, expand patient access, expand care coordination, some really kind of just very, very good across-the-board ideas. CMS has already reduced the original expectations of what people have to achieve to be successful in this area. For example, clinicians now have to attain 40 points in this category. Originally, the expectation was that they were going to have to do 60, so CMS reduced that a bit. You have activities of various weights, medium at 10 points, high at 20. You can put together any combination that you like. So if you want to do 4 medium activities, you can. If you want to do 2 20-point activities, you can. Totally up to you as to how you want to do that. This one, you simply attest that you have completed the improvement activities for a minimum of 90 days. And a little bit of a break, again, for small practices. If you're less than 15 or you're located in a rural or health professional shortage area, you are only responsible for completing up to 2 activities for a minimum of 90 days. So, you know, they're trying as hard as they can to reduce the burden from some of these requirements. As I mentioned a little bit earlier, the cost and resource use category is not being calculated for 2017, and they are also proposing not to calculate it for 2018. This is something that people did not have to actively report. CMS was going to take this information directly from claims data. They have to have a way to compare resources for similar care episodes across practices, and this line here really helps explain why they started with the groups that they did and why psychologists and others were kept out for a couple of years. When you look at physicians and when you look at physician extenders, such as nurse practitioners and PAs, they are almost always billing evaluation and management codes. So you're comparing apples to apples versus the many other healthcare providers who do not have access to E&M and so are always billing something other than E&M, in which case you then try to, how do you compare? It becomes apples to oranges, or it becomes you can't compare across groups, and it becomes much more tricky. So that's why they started off with the specialties that were predominantly using E&M codes, because it gave them something that they could use in order to compare these different practices. These area can be risk adjusted. Again, for 2017 and 2018, it's not being used as part of the composite score, so people are essentially not being penalized because of how they're doing on cost or resource use, but on the flip side, they're not being given any credit for it either. What CMS will decide to do with it later on, well, that remains to be seen. Well, we thought they would be ready to start using it in 2018, and they're not. So remains to be seen what they'll need to do in that particular category. If you are doing claims, you would need to report on at least 50% of your Medicare Part B patients. Again, keep in mind what I'm talking to you about right now are the requirements for 2017. What the requirements will be by the time we get to 2019 and psychologists are expected to be added, we do not know. We'll have a much better idea about that next year when CMS starts to discuss some of its proposals. If you're doing registry reporting, one thing that's a little bit different, and when I say registry reporting, it can be an independent registry like our MIPS Pro registry. It can also be a qualified clinical data registry. What's different about the registry reporting is you don't have to limit your reporting to Medicare patients. It can be 50% of all your patients as long as they meet whatever the measure calls for. So if the measure says people 18 years old and older, then if you have a 16-year-old patient, that patient can't be part of that particular reporting. But doesn't matter where they're coming from. They can be Medicare, they can be private pay patients, private insurance patients, does not matter. As I mentioned before, we do have an option for MIPS registry for psychologists, for those of you who are interested, whether you want a practice report and possibly be ready for a few years from now, or also you just want a practice report and essentially see how you're doing. We continued with the same company that set up PQRS Pro for us, that's HealthMonix. And the focus, as always, is that this is something that is meant to be as user-friendly as possible for mental health professionals, both in terms of our going in and identifying the measures that are most important for you to be aware of, and also because, having worked with us for a few years now, HealthMonix is very familiar with dealing with psychologists and the type of questions that they have, and understands that they are coming to it from a different perspective than physicians and others that have had more experience with some of these reporting issues in the past. So it definitely is a very, very good way to go, and we hope it's something that you'll pursue if you are interested in doing the practice reporting. There's a link to the MIPS Pro site at the bottom. Also very, very important that if people do want to do this, that they use this particular link, because that gets you into the website where the pricing reflects the arrangement that we've worked out with HealthMonix. If somebody were to go directly to the HealthMonix site and be trying to sign in through a different MIPS registry reporting option and not the APAPO one, you will see prices that are higher than what's available under APAPO MIPS Pro. Okay, I realize I've been doing an awful lot of talking, but if you have further questions, we still have time on this webinar for you to raise them. But also long-term, you are always welcome to contact Government Relations. I have the phone number there for our hub number. We also have a hub email address that you can use. You're welcome to send any questions there, and that goes actually for all questions related to Medicare, Medicare reimbursement, or advocacy. We have some information that is already on APA Practice Central, which you can reach through that link on reimbursement. And again, I'm repeating the link for the quality payment program on the CMS website because there are some very excellent resources there. And that's also a really good place to just go and kind of read through some of this if you're trying to get an idea of just what the program is all about. We did have some questions that were submitted in advance, and there were a couple of them that I wanted to touch on because I thought they raised some interesting questions. I mentioned before that no, it is not definite that psychologists will be added in 2019, although we certainly expect that they will be. Someone asked, in what ways could a psychology student prepare for this, and is there a need? I would say keeping up to date with the information that we have online is really one of the best things you can do. And I think it's important for someone, even if they're not yet practicing, to be aware of how this is changing, because you will not only see it in Medicare, but increasingly you will see issues related to quality improvement in private insurance. Also very possible in your first few years if you're not going directly into an independent practice, but perhaps you're working for someone else, perhaps you're working for a hospital or some other type of medical facility, that you may encounter quality improvement programs in that setting. So again, here's an opportunity to at least become familiar with what's out there now and what type of measures are most applicable for psychologists. And Jewel, did you have particular questions that people have raised?
Yes, we do. We have quite a few questions, so we'll see if we can get to some of them. The first is on the low volume threshold. Does that include Medicare, HMO, and PPO plans?
That's a really, really good question, and I am going to research that one for you and get back. If the individual who submitted that question, if we don't have their contact information, I'd invite you to send a message along to practicegov@apa.org, and I'd be happy to do a little bit more research on that for you.
Great. The next question is, would MIPS apply to group practices or to individuals within the group practice?
It can apply. There is a group reporting option. So it's really up to the group in terms of how they want to do it. They can choose to report as a group, or they can bill as a group, but then choose to do MIPS reporting as individuals. I think I mentioned a little bit earlier, then that actually gives them the opportunity to decide, if it works to bring them into MIPS to report as a group, they can take that option. But if reporting as individuals would keep some or all of them out of MIPS, then that's also another possibility for them.
Okay. They're asking a follow-up question. If it is a group reporting option, then do the thresholds change?
No, thresholds remain the same. So you could have a group that, does not see that many Medicare patients or does not see bill that much in Medicare charges and still ends up coming under the threshold.
Okay, great. Our next question is, if we are not required to participate but choose to participate, are we eligible for the bonus?
No, unfortunately, because it is trial reporting, the same thing that protects you from the penalty also does not allow you to achieve a bonus. You're practicing, therefore, there's no impact on your payment, even if you wish it was.
Okay. How do groups report if some clinicians in the group are ECs and some are not? Would reporting include data from professionals who are not ECs, and I guess that's eligible clinicians?
Right. Again, you could include their data. It would just be treated as practice, whereas for the ones who actually were ECs, then it would later on impact their payment.
Is there a way?
The good news here, I want to go back to that question. The good news is in that situation, because some of the providers were not ECs, if they didn't do so well in their reporting, all they would be receiving is feedback, so they would not be dragging down the group.
Okay. All right. If you are currently receiving reduction in payments due to previous penalties, not reporting PQRS correctly, for example, do these penalties carry over? I don't want to use the phrase carry over, because what's happening with those penalties is they were linked to a particular reporting year. So let me explain it this way. Technically, as a standalone program, PQRS ended on December 31st, 2016. However, your 2015 reporting data is reflected in the payments you're receiving in 2017. So if you didn't properly report in 2015, you are seeing penalties in 2017. And that also means if you didn't properly report in 2016 under PQRS, you will see penalties in 2018. So
The program itself is no longer eligible for direct reporting under PQRS, but you will still see the impact of those penalties if you didn't report successfully, because they are linked to what you did in the past.
Okay. How does a group practice or individual provider let Medicare know that we are exempt?
Medicare will determine that. Medicare will look at the claims that you filed, and they will determine whether or not you are considered exempt under, for example, the low volume threshold.
Okay.
So really, a good way to think of this is Medicare is looking at what you're doing this year to decide whether or not you're in for the following year.
Okay. We have one more question. At any given time, we have 1 to 4 Medicare patients. Do we need to report MIPS?
Highly, 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 highly. There's under the current low volume threshold, there is no way that you would be reporting MIPS.
Okay. And we just have
even if you had over the dollar amount, you would still have way too few patients.
And I know we talked about low volume threshold a lot, but we have another question. Once again, for group practices, does the low volume threshold just apply to each individual provider or to the practice at large?
Again, it depends on how you want to treat it for MIPS purposes. If you want to be reporting MIPS as a group, then it's going to be applied to the group, which means you might have enough between the different providers and the dollar amount to get you over the low volume threshold. But if you determine that for MIPS purposes you would prefer not to be treated as a group, then you can break it down under each individual provider's NPI number.
Okay, we have another question. How does Medicare know if your group wants to report as individuals? Could the group get penalized?
That's a great question. Again, send that to us as an email, and I'll be happy to try to find some resource that can spell that out a little bit more carefully. We do have a number of things, and we used to see this with PQRS too, but definitely we've seen this in MIPS. We do have a number of different parts of the program where CMS has said what it's going to do, but it hasn't totally explained how it's going to do it.
Okay, and we have one more question. Can you talk a bit more about what clinical practice improvement activities are and what is involved with these?
Well, they are a number of different activities, and they're very, very, very broad. And in fact, the ones that I showed on the slide are just some of the ones that are specific to behavioral and mental health, but there are many, many others that psychologists can choose from. Just because something's under another heading doesn't mean that psychologists can't make themselves available. So some of it's related to things like, what hours are you available? What mechanisms do you have for patients to contact you? Can they contact you through email? Do you have an emergency number? Things of that nature. It's very broad, but the whole point of it is really to not only be finding ways to improve your practice in terms of the clinical work that you're doing, but just in terms of the operation of your practice to make it more patient and user-friendly.
Okay, well, thank you so much, Diane. That's all our questions. And thank you, everyone who attended this webinar. If you have any more questions, you see there's information on the slides. You can email prac.gov@apa.org. And of course, practice organization members can access additional resources through our complete guide to Medicare, which is available at apapracticecentral.org. Again, a quick survey of this webinar is going to be emailed to everyone, along with a recording of the webinar to everyone who registered within the next 24 hours. So thanks, everyone, for joining us. You have a great afternoon.